If you're interested in the idea of stem cells or PRP, either for osteoarthritis or osteoporosis, you're going to want to listen to this interview. So today I interviewed Dr. Richard Schaffer. So Dr. Schaffer is a founding partner and board member of QC Kinetix, which is a unique non-surgical orthobiologic regenerative medicine practice with over 180 locations nationwide. So I wanted to speak with Dr. Schaffer. I've known him for a while, and he has done more research on the topic of stem cells and PRP and amniotic fluid and bone marrow aspirate than anybody I know. So he has developed the protocols, he and his team have developed the protocols for QC Kinetics, and we go through a lot of that today. We talk about PRP, we talk about A2M, bone marrow aspirate concentrate, and that backs us into a conversation around stem cells. And we get a lot of questions about stem cells because there's a lot of famous individuals and influencers who are talking about stem cells and how they've helped them with various conditions. And so we talk about what is really a stem cell, what's available currently in the United States, what to look for, what to look out for, and really who would benefit from the things that the regenerative options that QC Kinetics is offering, specifically PRP, A2M, and bone marrow aspirate concentrate or BMAC. So this is a really great conversation if you're interested in learning more about the things that are currently available in the United States and eventually worldwide with QC Kinetics. And my take on my personal experience as I'm going through this process right now for arthritis in my right knee. And so I have had one of a series of 3 injections, and I give my little anecdote of how that's going so far in here as well. So enjoy this interview with Dr. Richard Schaffer from QC Kinetics. All right, Rich. Well, thank you so much for joining us here on the podcast and YouTube channel. I am really excited for this conversation because we get so many questions about PRP, stem cells, regenerative medicine, non-surgical options, because so many of our listeners have joint pain. They also have osteoporosis. They've got a lot of stuff going on, and they really are looking for what is an economical, time-sensitive answer to their problem so that they can do the things that we're asking them to do, which is be more active, eat better food, lift weights, and use these joints again. So this is a conversation way too long in the making. So I'm super glad you're here, Rich. And let's just start with this, which is tell us a little bit about how you got into this space, because you haven't always been in the PRP region space. So where did you come from?
Well, I'm a board certified family physician by trade. That's what I did my residency in. But when I was in residency, I had a really fond interest in sports medicine, especially non-surgical, since I'm not a surgeon. And I started volunteering to be a team physician for some local high schools in the Virginia area that I was doing my residency. And then I also had the fortune of being able to do a couple of rotations at Virginia Tech with their sports medicine department. I got to work with their orthopedic surgeon, their primary care doc. And what was evident to me was that we needed a lot better non-surgical options for athletes specifically. That was my population I was working with, to get better, quicker, faster, or heal and repair stronger after surgery. And that's where I started digging into initially some information about PRP, which at the time when I was in residency, that was really the only thing I knew was out there, but it really wasn't the US. I finished in 98. So there really wasn't a whole lot of PRP being done in the US at that time. And long story short, I had the opportunity about 10 years ago to be in a practice that was open to me starting to do some of these biologics, where you're actually using your own platelet-rich plasma specifically to heal and repair non-surgical injuries, tendinopathies, help with the knee pain of OA, osteoarthritis, things like that. And one thing led to another, and I had the opportunity with a couple of colleagues, a physician assistant that was working with me at the time, and a business colleague that were working. We decided to go off on our own and try to open a clinic that was just focused on these things. And so we met with I guess the 3 of us met probably in 2015 or so. And then it was 2017, we decided to do what we're doing with QC Kinetics.
Yeah, that's awesome. And I think you and I first met, it was probably 2019, I think, early 2019. Because it was shortly after we moved to Asheville.
Yeah. And actually, you reached out to me and said, "Hey, what are you guys doing over there?" Because we opened an office here locally, and you were curious. And I remember having lunch with you both, and we had a really nice conversation about it. And it was refreshing for me for an orthopedist to actually approach me and say, "What are you guys doing over there?" So that was neat. I really appreciated that.
Yeah. Well, and I was in practice at the time, still operating, and a foot and ankle as my subspecialty is an area where we really need better non-operative management options. Because while surgery can be great for the foot and ankle, there are a lot of surgeries that have subpar outcomes simply because, fusing bones together, repairing tendons, it is sometimes underwhelming. I'll put it that way.
Right.
And so I was excited to hear about these things because there wasn't a lot of literature, especially at the time, for PRP specifically in the foot and ankle. Some better literature in other joints. So it's been fun to watch you grow, though. So we've continued to keep in touch, and we've actually now share some colleagues. And I would love for you to just give us a sense of kind of how this has grown, because I think it speaks to a number of things. But number one is the demand that we're seeing for what you've figured out. So what's happened with QC Kinetics since we met in 2019?
Wow. So in 2019, we'd been open for about a year and a half, I think, when I met you, and we had some clinics in just the Carolinas. And we were really excited about the demand. It all started, believe it or not, in a clinic in Mount Pleasant, South Carolina, which is sort of across the river from Charleston. And we started off one day a week. We were doing Saturdays only. And that's all we did was one day a week there, because we were all three of us were working in Charlotte at a different practice at the time, and the demand just grew rapidly, and we were just surprised at how full the schedule was getting. And so we were challenged basically by the demand to see if we could open other offices. So basically, we went from Charleston to Charlotte, and then Charlotte to Asheville. And so I think when you and I first met, we had about 4 or 5 locations, and that was out of the necessity of each location and city showing us that we could get a full schedule, and people were interested in it. And part of what happened was that we started in those markets to mainstream commercials for what it is that we're doing. And most of it was that patients just didn't know what we were talking about. And so we had to get that out there and establish it. We did, and then that demand rose quickly. So to get to where we are now, what happened in sort of a meteoric fashion is that we decided, how can we scale what we have across the country the most efficiently and effectively way possible, and get out to as many markets as we can? Because while these treatments were available, most people didn't know about them. Doctors are afraid to market. They're not willing to spend the money to educate the public. And we were excited with the results we were getting with the protocols. And so we decided to franchise. And after a lot of consultation with lawyers and business people and all that kind of stuff, we decided to do that. And that's how we scaled quickly. And we opened our first franchise, and I want to say January, let me think about this, January of 21. Maybe early February. And we went from our 6 or 8 locations then to where we are. So January 21 to today, where we have probably 170 franchises across the country, locations, physical locations, brick and mortar locations. And then we have 10 to 15 corporate offices now in the Carolinas, Alabama, places like that.
Yeah, such an amazing, and meteoric is, I think, the right term for that. That's a very rapid expansion from a franchise perspective. But it just goes to show the demand, and then the scalability of what you're doing, which is so cool. And I want to share with you my experience, because when we first started talking about this, I was talking about initially selfishly just saying, man, my knee hurts, and I had I'll just give my case as an example. So I'm a 46-year-old man. I had I'm not seeing the inside of my knee, but I probably had a near total meniscectomy. So the meniscus, the cartilage disc, I know you know this, Rich, but the cartilage disc in my knee on the outside compartment of my knee, which is prone to degenerative arthritis when you take it out, when I was 18. So the surgeon at the time just basically lopped the whole thing out, which we don't do anymore. But that's what happened. And then I had a second injury with whatever cartilage and disc was remaining was removed in the second surgery. So I probably have no meniscus in the lateral compartment of my knee. Historically, if you look at studies, it'll take about 10 years from that surgery, that subtotal or total meniscectomy, to develop severe degenerative arthritis. This was when I was 18. and then I think again at 20. So now we're 26 years out. And my knee looks on x-ray, meh. It looks okay. I've got some joint space narrowing. I've got some osteophytes, which are bone spurs. But I still have pretty good alignment. And so I reached out to you, Rich, and said, hey, I would love to explore your protocols. And then while we're doing it, let's educate our audience, because again, I have the opportunity and privilege to sit here and educate individuals who are looking for these solutions. So I wanted to go through this myself. And I can tell you that my experience so far has been just so easy. And I think this is a barrier that a lot of people they just put up to say, oh, this is a challenge. This is the medical system. But you, as I am now, are essentially outside of the traditional medical system, right? So we are in the business of both patient care, but also patient experience. And so it has been so easy, essentially, to make a flexible appointment that works with my schedule, which is not easy, going in, and I've had one of what will be a series of 3 shots. Let's walk through some of the protocols. So when I went in and I met with one of your PAs. Mm-hmm. She was fantastic. And she made me feel very at ease, because I've done joint injections for years. I've done thousands of joint injections. And I know it's not always that easy. Now, the knee is a pretty wide open joint to hit, but I've seen it missed a lot. Mm-hmm. But she gave me so much ease, because she's talking about all these different things because we were going through all of my musculoskeletal pain, which I have a fair amount of. And she was saying, oh, we can get into the sheath lining of this, and we could get into the, around here on your Achilles. And I was thinking, wow, mm-hmm. You're really good with a needle. So then getting into my knee joint obviously was very simple. But let's talk about protocols. So for me, I'm doing a series of 3 injections. And when I actually did PRP in practice, but as you mentioned, orthopedic surgeons, even sports medicine docs who are in the non-operative space, we are terrible at marketing. We don't really know how to market. We don't know how to educate our non-patients. And then we aren't really set up to do cash pay. And insurance doesn't, I'm sure, I don't know if it does now, but it didn't then cover these types of injections. And so I would really only have an opportunity to do a single injection. So when you first said protocol, I'm thinking, man, why would we do a protocol? So give me a little background on how you develop these protocols. And I wrote down a couple of things I want to talk about. Well, I'll fill in gaps if you miss any that I want to hit. But let's talk about some different protocols that you guys have developed, because you are treating a lot of different things. It's not just knee pain and arthritis. Right. So what are some of these protocols?
So the protocols are all based in foundation on PRP, and we can get into a little bit of that and what it is exactly for the audience at some point. But they're all based on using the platelets as sort of a foundation for what we're doing for healing and repair. And what we wanted to do when we started our protocol was to not sort of do a one and done on folks with PRP. I just haven't seen the literature that shows doing one PRP is ever enough. I've seen as many as people doing 4 to 6 injections kind of once a month. I've seen 2, I've seen, all these things. We settled on 3 because I felt like I had the most evidence for that was the most consistent thing. I think there are lots of variabilities like timing, like when and how, and there's not as much detail on that, like what's the exact right interval. We have a good idea, so 2 to 4 weeks between injections kind of thing. And so we settled on 3 to start with. That was the foundation of what at the beginning of the practice was. Now we added other things into the protocol as we matured. And so initially we were just doing PRP. Then we added alpha-2 macroglobulin as a separate injection. We can talk about the details of that to some degree. And then we added in bone marrow aspirate concentration, which some people might refer to as a stem cell treatment. I don't like that moniker, and I can explain why about that. But these all have different mechanisms of action. And so my point in having all 3 of the main options we have, PRP, A2M, and BMAC, bone marrow aspirate concentration, was to have different mechanisms that were attacking the problem that was causing the person pain. And so that's how we started. And then we've morphed into having multiple protocols now that we have some for, say, acute phase injuries versus somebody who comes in with I don't know, 26 years of osteoarthritis or developing thereof. So I may do something a lot more aggressive with that person than, say, somebody who comes in with a tennis elbow or a golfer's elbow for 2 months. So I wouldn't necessarily throw the kitchen sink at that problem. But I would do multiple injections, and I have yet to see anybody literature-wise that I thought did a good study by saying, let's just do one PRP and compare that, for instance, to a steroid injection. Well, it's not a fair comparison. First of all, they're very, very different creatures in how they work. One's degenerative, one's regenerative. But also you need more than that to jumpstart your body's healing and repair system to do what we know it can do for itself. And the beauty of all of these, of course, is that it's all the best of you. It's your own growth factors that we're harnessing. And that's a very exciting thing to be able to do in this day and age and not be a drug.
Right. Well, actually, that's a great segue into this idea of, you call it regenerative, non-surgical regenerative options, right? And I think that's a really great word. I do want to get into stem cells, but let's not go there yet.
Sure.
So when I was practicing and doing a lot of joint injections, the vast majority of what we did, especially in the foot and ankle, were steroid injections.
Yep.
Mostly because it was driven by insurance, right?
That's
so we could get those injections paid, and they provided relief. But what I always counseled patients on is steroid will break down the articular cartilage. It is destructive. Pain relieving temporarily, but it is destructive. So we know if somebody has, say, midfoot arthritis is a really common reason to do this, or ankle arthritis. If you have destruction of the joint, and we know that we're going to end up fusing this thing anyway, or replacement maybe in the ankle if that's the case, then this is okay. But if our goal is not to go down the surgical pathway, what are our other options? And in the foot and ankle, we didn't really have any.
Right.
Now in the knee, we have the visco supplementation option, which has been around for, decades.
Yep.
And, I look at that as it's sort of like neutral, right? It's not really destructive. It's not really regenerative either. It doesn't do anything to the joint other than just improve lubrication. I consider it like the motor oil of the joint. Is that a fair supplementation? Or is that a fair assessment of what it's doing in the joint?
I think so. I think I think though that there's some decent evidence, interestingly, on the gel shots that you're talking about that people would know, the visco supplements, that it actually improves hydration of inflammatory bone areas around the joint, and that seems to help relieve pain. There's some evidence that it's not just, for instance, lubrication of the joint until it's not there anymore. That because it's such a hydrophilic molecule that it's drawing a little bit more hydration there and helping decrease inflammation and helping the bone tissue there. But again, there's not a ton of that. There's some. Certainly most people feel like it's the viscose supplementation is exactly that. It's viscous. It's helping to grease and oil the joint. And I believe that's true, but it's probably not the only thing that it's doing. So I actually like viscose supplements, but what I found with them is they have a time limited effectiveness for most people. The more you do them, the less they work, the less they work, the less they work. Not that there's nothing wrong with doing them, but I just find that they tend to taper off in effectiveness over time.
Yeah, and that was my experience too. So I spent the last 2 years of my practice doing more general work. So I was doing less foot and ankle, and I would do more big joints. So we were doing a lot of knee injections and finding success, clinical success. I'm using quotes for those listening to this. Clinical success with both steroid and visco supplementation. But you're right, I did see that declining benefit of visco supplementation. And then same thing with steroid too, because as the joint degenerates, at some point you're just going to need to have a replacement.
Right.
So then that brings us to then the idea of let's regenerate something. But this is a very confusing term, I think, for a lot of people. And I think the expectation is I'm going to grow all of my cartilage back.
No.
So walk us through, what are we actually seeing? And I guess you could go through some of the different things. So PRP versus A2M, you mentioned alpha 2 macroglobulin. So A2M, the acronym there, versus BMAC. What are we really trying to do with each of these approaches?
Great question. So this is what we get into in terms of why do we care about platelets to begin with? And we care about platelets because they're phenomenal housers of growth factors like epidermal growth factor and VEGF, like vascular endothelial growth factor, things like that, platelet-derived growth factor. So how do we access those? Well, you access those by putting platelets in a place they wouldn't normally get in a concentration they wouldn't normally get. And so what we do fundamentally is, we're just drawing your blood, spinning it down in a centrifuge, separating the red cells out. We don't need them. It's all the plasma. Then we hyperconcentrate the plasma to increase your platelets in that plasma, and then we can inject that into your joint. Well, okay, great. How do we get access to the growth factors? Well, by actually spinning them down, putting them in a syringe, and injecting them into the joint, you're doing what's called activating the platelets. And by activation, that means they rupture, they lyse, they burst, and they release all these growth factors in the environment into which we put it. And people always ask me, well, doc, why is my body putting all these platelets in there to fix this anyway? I'm like, because the circulation in the joints is terrible, and healing and repair in the joints is terrible. So we're just taking a huge amount of platelets, and we're specifically with PRP, and putting them into the joint, letting all those growth factors help to heal and repair the tissue. So will you grow a new joint and a new meniscus? No. But what we can do with these growth factors is to actually help the tissue that's there do the best it can to heal and repair itself with these growth factors. Because why? What do they do? Well, probably the biggest thing is that they can help stimulate the fibroblasts to make more new collagen. They can help signal other reparative cells to come to the joint. So cytokines, as we say. So there's cytokines that are calling other cells to this area, which we can get into in a minute. Then we've got chemokines, which are chemicals that are actually signaling and stimulating the cells in the area to help heal and repair. And then it's an anti-inflammatory process. And you have multiple anti-inflammatories that are in the plasma as well. So there's a lot of incredible growth factors, chemical signalers, chemical meaning biologically chemical, not artificial. All these wonderful things that we're harnessing with platelets to help heal and repair tissue and decrease pain. Because ultimately our goal is quality of life and decreasing pain. Because a lot of times people will say, well, doc, I want a pre and post MRI to see what the layer of cartilage you've grown back is. And I'm like, that's a waste of time and money and exposure to magnetic energy that you don't want, because you're not going to necessarily see this layer upon layer of new cartilage growing in the knee. That's not what it is. I base things on quality of life and pain. So our whole focus is your quality of life. So I want to know, why are you coming in to see me? And I joke with people all the time. They come in and they say, yeah, I'm here because I have knee pain. I'm like, no, you're not. And they're like, what do you? Yes, I am. And I'm like, no, you're not. You're here because your knee pain is now causing enough discomfort in your life that you want to do something about it. That's a very different thing than saying, I'm here for knee pain, fix that. I want to know, you can't get on the ground and play with your grandkids. You can't bowl, you can't hike, you can't fish, you can't, whatever the case is, so that I know that I'm following that. But platelets are really loaded in growth factors, and that's why we like them so much. Let's talk a bit about A2M or alpha-2 macroglobulin, because I bet that's something that a lot of people haven't heard of before, or why we would want to use it. It's a really incredible protein that's in the bloodstream that we can harness and concentrate and put into a joint. Why would we do that? The biggest reason is that it's a protease inhibitor, and part of the process of arthritis, or part of the biologic activity in joints, in terms of an inflammatory process, are these proteases that are enzymes that are gradually, every day, just little by little, because of the inflammatory markers, they're breaking down your tissue. So cartilage, bone, surface, things like that. Well, alpha-2 macroglobulin is a really interesting molecule that will go in there and actually inhibit those enzymes and actually stop them, which is really neat. And this is a molecule that we learned about probably in 2017 or 18. There's some neat research being done, and we decided to add it into the protocol. And I would tell you, one of the neatest cases that we saw right off the bat was somebody with chronic knee effusion. And we were down in Charleston, and we had done PRP on this person first, and then they came back and they were doing their A2M injection. And this person was one of those people that had a couple of knee surgeries done, and all they could do was have him come in once a month, pull the fluid off of his knee, stick a steroid in there, and that was all they were doing. And basically, it was just walking towards a knee replacement. And so he came into us and said, is there anything you guys can do? And we said, well, we don't know. We're working with A2M. This was probably 2018. And we worked with A2M in this knee. And what was amazing was how the knee effusion got better and better and better. We actually had his orthopedic surgeon call us up and said, what are you doing? Because we've been trying to do stuff for this for a long time. And we said, we're using A2M. We're using A2M concentrate, which is a plasma protein concentrate that we do with our filtration system. And it was really exciting. So that was one of the things that really got us to say, okay, we need to put A2M in regular protocols, especially for those people with OA or osteoarthritis or any kind of arthritic process. And it's become a staple in our protocols. I don't know how much you want to get into bone marrow aspirate. I can talk a little bit about that, or did any of
Yeah,
that
well,
seem
and
really
I guess, so here's a question. So I actually had never heard of A2M until I
Oh,
was in your clinic 2 weeks
okay.
ago. So,
Oh, wow.
yeah.
Okay.
So that was the first time I'd heard of it, or maybe I heard you mention it, but I certainly never used it. And we were only talking PRP in the clinic. And then I actually used bone marrow aspirate concentrate and BMAC in the operating room.
Oh, cool.
And,
Yeah.
I did.
Yep.
I did that because I can stick a big gauge needle into somebody's pelvis in the operating room under anesthesia.
Yeah.
But there's an easy way to do that in the clinic. I was just never willing to do it. So we don't have to get into BMAC too much. Other than in general, would you say PRP A2M is kind of your go-to for the arthritis patients? Is that your combo?
Well, I use a lot of BMAC in arthritis patients too. It depends on the level of the arthritis and the level of pain and dysfunction somebody has. Because bone marrow is very, very potent. I mean, bone marrow aspirate, not bone. I shouldn't say bone marrow. Bone. I need to clarify. It's bone marrow aspirate. It's not bone marrow, but it's bone marrow aspirate, and we concentrated it. It's very potent and has some incredible cellular components. I mentioned earlier about people calling it a stem cell treatment, and I don't feel like that's fair because it's such a small part of what bone marrow aspirate has in it. Yes, it has mesenchymal stem cells. Yes, it has hematopoietic stem cells. Yes, we love mesenchymal stem cells, which have actually been renamed by the industry as medicinal signaling cells, not mesenchymal stem cells. And that was by the person, Dr. Arnold Kaplan, who actually discovered them in, I think, 91 when he first isolated them. But they've kind of gotten too much credit, I think. They're very important, and they are very potent, and they're helpful, and we certainly concentrate them in bone marrow aspirate, and I'm excited to use them. But it's everything else that's in the bone marrow aspirate plus the stem cells being in there that work together synergistically. And actually, all three of these products work together. So there are some practices that will combine a PRP and a bone marrow together and put that in the same joint in the same day. I don't do that, and we can get into the reasons why at some point. It's probably not that, probably for a different discussion. But some people do combine them, but there's synergistic properties among all three of these things. They work well together, and using bone marrow aspirate is probably the most aggressive thing that we can do for somebody. And so I do use it regularly. I don't use it for things mostly like tendinopathies and things like that when somebody's got pain there. But if somebody's got really bad OA and they want to do the most aggressive thing, I'll do it. And as you said, it's got a bad rap as a procedure, but I can tell you I can do one in 9 minutes under local anesthesia with lidocaine, and people feel pressure, they feel a little pulling sensation, but I'm in and out in 9 minutes, and it's actually, I probably take longer than re-injecting it into the areas that I re-injected into. And it's way longer to actually spin it down and concentrate it than it is for me to pull it. So It's a pretty easy procedure for people.
And are you using the posterior crest then?
I am. To me, and I've talked to some colleagues about this and seen some papers on it. There's certain techniques that get you better yield, certain places that get you better yield in terms of cells and quantity of aspirate. There are other places to take marrow from, the calcaneus and the heel or the shin, but the numbers don't ever seem to be worth the patient going through that. And it's just so easy to do the posterior pelvic bone, and people tolerate it very well.
Yeah. So we actually had, right as I was exiting my private practice, we had a doc start doing that in our clinic. So I was like, what? Man,
I love the procedure. I really do. I mean, I think
and I always had to use the front because my patients in the foot and ankle world were almost always supine. So they're almost always laying on their back. So I would have to use the anterior iliac crest, which is cell rich, but harder to get into.
Yep.
And I wouldn't recommend trying to train people to do that, especially not in the clinic. So let's actually deviate into stem cell a little bit. So you kind of mentioned the two cells that we see in bone. I get a lot of questions around stem cells. There are some books out there. I won't mention them, but a couple of very famous people have made stem cells even more famous. And I see people that want to get a quote unquote stem cell injection in their joint
Mhm.
But then I also hear stories of people who say, well, I went to, wherever in South or Central America, and I got an injection of stem cells into my either, like my venous system, right? So they did an IV of stem cells.
Mhm.
And then also I have some, we'll call them friends, who like to use the products where there are stem cells and a little like topical patch that
Yeah.
somehow do something through the skin.
Yeah.
So can you give us a rundown? So from those kind of the into the joint version versus intravenous versus topical, which of those is actually doing something from because you've read more research about this than anybody I know. So which of these is actually doing something, and which of these can you actually get in the US as a kind of another follow-up question to that?
Yeah, well, I mean, there's certainly different types of stem cell products that you can get in the U.S. I would challenge a patch of any kind to have any significant clinical results. I haven't seen any papers that have compared that. Like, for instance, say you put a patch over your knee instead of doing a bone marrow aspirate injection or a lipo aspirate. We haven't talked about that at our practice. We're not doing that right now, but you can actually get a really nice quantity of stem cells from your own fat. You can do a mini liposuction without getting too deep into it. You can capture some mesenchymal stem cells from your fat, which is a really good source of them. You can get those like fat injections in the United States that you can do into the joints. The real issue for me with things like that is FDA compliance. So in the United States, the FDA is very specific about what it considers a drug process and what is not a drug process, and what is homologous use versus other use. And so they like you to take a product and use it for a homologous purpose, meaning it's a similar purpose for what that product is doing in the body already. I hope that makes sense, but that's
Yep.
what it is. And so a lot of these products, you have to be careful of FDA approval, meaning whether the FDA considers them a drug and regulates them as a drug. And it does not regulate bone marrow as a drug, but it depends on how much you process a specimen. So there's that. But in regards to the specific treatments and therapies you've met, I've actually seen a lot of decent research on IV stem cells that you cannot get in this country, to my knowledge, legally, unless you're in a medical study at a tertiary healthcare system or a clinic that actually has study approval from FDA, and they've given them the grant to do that, and they're collecting data on that. I don't know of any commercial retail medical practice where you should be getting IV stem cells in the United States. To my knowledge, that's not legal. That doesn't mean it's not helping people. So there's some excitement around some anti-aging things. There's some excitement around some chronic disease processes and autoimmune things. So things like lupus and psoriasis and even some of the neurodegenerative conditions. There's some excitement about what some of the IV stem cell therapies are doing. What I can't tell you is that I've vetted clinics overseas that I could say that you should go to. I can just say that they're out there. I can say the data is encouraging and exciting. It's probably going to be a while before that's in the U.S. So I don't know of anything in the U.S. that you can get IV. But I do know the intra-articular injections, the lipoaspirate injections, and bone marrow injections, which all have stem cells in them. Those things are available. A patch, I just have never seen anything I could say is clinically efficacious there. I'm more than willing to be proven otherwise. I just haven't seen anything on that.
Yeah. And the other buzzword that I hear is exosomes. And if this is a little bit out of your space, that's fine. But I thought I'd bring it up just because people will put them all together, right? So,
Yeah.
so what are your thoughts on exosomes and how they could potentially fit into this picture or not?
Okay, so I'm gonna expand it a little bit further, which is I'm gonna say exosomes, all afterbirth amniotic membrane products, all these things are things the FDA considers drugs, and technically you're not supposed to be doing exosomes in this country. And I can tell you because I care. I work with an FDA attorney out of Washington D.C. who worked at the Human Cells and Tissues Department at the FDA and prosecuted practices that were doing things like this for about 13 years. And he is my backstop about what the regulations say. And currently, while I am personally excited about exosomes, and I know they're out there, I know people are doing them, you probably shouldn't be doing them clinically. And I know a lot of people would argue with me about that, but the FDA has been pretty darn clear about that. I'm excited about them. I want to use them. I prior to the FDA calling the amniotic membrane products a drug. That's what they've assigned that as a drug. It's more than minimally manipulated. There's too much you have to do to the product to get the product that you put in the vial that you then inject. The same is true with exosomes, and exosomes is still a bit of a wild, wild west out there. There's not standardization of how we use exosomes, how we obtain them. But I'm very interested. I would love to use them in my practice at some point in time and even do studies on. These are things I would love to do studies on with companies and say, let's look at your product, let's get a safety study going, and then let's get a clinical study going. Let's show this stuff is safe, works, and let's go. But the FDA is pretty harsh on those things. So I'm not against them. And again, I support the expansion of research in these areas, but I would think that you need to do some digging if you're going to pursue exosomes, not because I think they're terribly unsafe or anything like that. I'm trying to toe the line on that. I want to see us have more information on this. I want to be able to clinically utilize these things. But I also want to make sure we're doing things under the right approvals. And so that's what I would say about those guys.
Yeah. And I think where people get, I don't know, confused is not the right word, but when I see providers who really push boundaries, because I know people who are using exosomes in practice, and when I see them push the boundaries, my fear is that it will actually end up limiting all of us by using them in the future. Right? If you push back too hard against the FDA, then you might find a very hard line that prevents us from being able to leverage them in the future. Well, that's my big fear.
Mm-hmm.
Yeah,
I can confirm that for you with amniotic products. I used to use them, and I probably treated thousands of patients with amniotic products over a several year period prior to the FDA determining their drugs and taking them off the market for all the intents and purposes. There's a lot of argument about the companies that manufacture these products about whether they're legit, meaning whether they're FDA approved or not, or whether they're under FDA guidance or not. But they're selling their product to me. And until they convince me that the FDA has approved their specific product, I don't feel safe using it because of the FDA, not because I didn't have good results with them, not because I never had a joint infection with them, not because I had great success with them, but I'm also trying to stay as compliant with the FDA's rules for what I can use as possible. So the example you just gave is exactly what happened with amniotic products. What ended up happening was a lot of us were using them, had no problems. And then people started doing crazy things with them and injecting them all over the place and then calling them a stem cell product and stem cell therapy. And they're just not. And so the FDA said, oh, that's too much. So you know what we're going to do? You guys, you process these things a little bit too much. That's a drug. Until you get it approved as a drug, you can't use them anymore. Again, the companies out there that sell them, they say, oh, no, we're not under those regulations. But again, my attorney is saying that's not true. And so that's why I don't use them, not because I didn't have good success with them and like them and I had way fewer adverse reactions with that product than I ever did with a steroid injection. So
yeah, I can see that.
Or gel shots. The gel shots, people have reactions with those too. You probably saw that. It's not fun.
I've definitely seen that. The knee blows up and they think they're infected and I think they're infected. It's a challenging problem. Yeah. So we've gone through a lot of things. Why don't we just summarize this by saying, man, if somebody is having, let's call it joint pain, musculoskeletal pain,
sure.
Who do you think is the right person to seek out QC Kinetics? Who do you think is going to have the best opportunity to see benefit?
Yeah, I think what I would say to that question first is a sort of a layered answer. The first is, if you know that you're experiencing pain due to osteoarthritis, the sooner you get to see me, the better results I can get. What I can tell you is, as you know, I don't know how much you want to explain to the audience, but there are several grades of osteoarthritis. And if I see you at, let's call it a grade 1, I have a way greater chance with what we do to get improvement in your pain profile and functionality than I do when you're a 4. So some of that is if you know you have it and somebody has said, yeah, you're at the early stages, the sooner you can get involved in some of these biologic products, autologous biologics, the better results you're going to get. That's becoming very evident. But I would, on the second level of that, saying even if you're at a grade 4, I used to turn those people down and say, no, that's just too much. You're too far gone. You need a knee replacement. And then what I had happen was I had these grade 4 people come back to me after I had turned them away and say, well, but I'm not eligible for surgery. Either I weigh too much and then I can't exercise. I have too many medical problems. I can't. And they said, will you please treat me? And I said, okay, I will, but I'm not promising you anything. And what I started to see was some of those people would get some nice relief. And so now I think it's a matter of counseling anybody and everybody with different levels of arthritis on where they are in their disease process, and then what we feel like we can do to help them with pain and functionality. That's not the only thing we treat. It's certainly by far the most common thing. Again, we treat tendinopathies and pain caused by rotator cuff problems, pain caused by tennis elbow, golfer's elbow. We treat wrists and fingers and ankles. So the most common joints we treat, frankly, are shoulders, knees, and hips. Those are the biggies. But there are many others that we will work on depending on what the condition is.
Yeah. And the cool thing about using needles in clinical practice is that, man, you can really get a needle just about anywhere.
Mm-hmm. Yep. Agreed.
Okay. Well, why don't you just give us a little sense of how people can learn more about QC Kinetics? And I'll just actually, let me summarize my experience so far. So I don't even know what my grade would be, honestly, because I haven't seen an x-ray of my joint in so long. But I have what I would consider mild arthritis. My pain is intermittent. So if I do deep squats, I don't run. That's probably why my knee looks as good as it does 26 years later. But I don't run. I don't do impact outside of, interval training. I ride bikes and I do resistance training. But if I use a very deep range of motion in my knee, it will ache. And once it flares up, it will ache for weeks. Mm-hmm. So prior to my PRP injection, I was in a what's called mild to moderate amount of pain. And the PRP injection kind of pushed it just because of the volume of fluid in the knee. Kind of got worse for a minute. And then it's been feeling much better. So pretty early pain relief from a single PRP shot. Before you tell us where we can find you, will you just give me a sense of, do you see relief in between shots? How long do you think it could last? And then we'll get into that last part.
Yeah, of course, that's a varying answer depending on the person because of how much they use their joint. But if somebody, like you said, the hardest folks for us to treat are runners because they won't stop. Mm-hmm. And so they're doing the same thing over and over that caused them to get where they are. So, we have that conversation with them. It's like, look, here's the relief you're going to get, but keep doing what you're doing. Yeah. But it's fun to get runners back to being able to do 5Ks and even marathons that they weren't able to do before. So that does happen. I find that there's an interesting variable with the first injection. And I say probably 30 to 40% of people will get some relief after the first injection, and then 60% maybe don't. And so it's funny because I have that conversation with the patients. They come back and they say, hey, I've already gotten some relief. And I say, wow, that's great. And then the person that comes back and says, yeah, I had an injection after the first injection. I didn't have any relief. I said, wow, that's great. Remember, we talked about it. This is a long-term the answer is the same because it's a long-term prospect. And where you're going to get your long-term relief is over the healing and repairing process that happens over months, not weeks or not right after a PRP shot. Because if you think about it, as I mentioned earlier, all the growth factors and anti-inflammatories that are part of the plasma product are going to decrease your inflammation acutely. But the long-term play is to do the repetitive injections and get more healing and repair so you have a sustained amount of relief. Again, depending on the person, how active they are, how serious the condition was. We've seen people that have gotten 5 years out of what we do. Is that everybody? No, but it's a good number of people. And then we see people that get, a year, 18 months, 2 years, and they come back and they do one PRP almost as a bridge or a booster. And they do that. And we've seen them sustain and not have to go to surgeries as well. So there are multiple factors. someone's health, someone's activity, how they're using that joint or that particular injured area or osteoarthritic area. But it's really neat when you commit to the process and you say, okay, this is a 3 to 6 month process for me, no matter what the injection did for me the 2 weeks after I got it. Because to me, it's easy for me to say, but that's not really what I'm excited about. I'm excited about the long-term prospect and then helping you to bridge that gap over time.
Yeah, well, that's a great way to look at it, and I'm sure that patient education can be challenging sometimes too, because people tend to forget those things. So, all right, last thing, where can people find us?
Well, I mean, for me, it's our website, qckinetics.com. So QCKINETIX.com. That's got all the information out there about us and all of our locations. As I said at the outset, we have about 180 right now, active locations. We're adding more this year, so we'll probably be close to, I'm hoping, the 220 mark by the end of the year, but that may be aggressive on my part, just in terms of construction costs and all those kinds of things and delays and things like that. But we're in probably 30 states, I would say, at least. And we're from the West Coast. I mean, we're out from Maine to Los Angeles to Miami. I don't think we're in Washington State yet, but certainly Idaho, places like that, just trying to give you an idea of across the country. So we're not just on the East Coast or anything like that.
Yeah.
So there's probably something near most of your viewers in this country. And then, of course, we want to expand internationally. We're working on that now, especially in Australia, New Zealand. Great Britain has had some interest, Spain, all of those areas we're looking at moving into next. So I think that's the best way, is to just the website has got tons of information, our phone numbers, and please give us a call and let us answer your questions. We can. Hopefully we can do either a telemed visit with you or bring you into one of the practices.
Yeah. Awesome. Well, thank you, Dr. Schaffer. I hope this answers those questions around stem cells and what people are hoping to do. One thing we didn't talk about, and I just wanted to mention, because I know I'll get comments on it. I actually, when Rich and I were planning this conversation, I had brought up the idea of, hey, is there any evidence around osteoporosis? And my research on stem cell and osteoporosis has yielded nothing. And Rich, I assume that was true for you as well. Yeah.
I haven't seen it.
Yeah, and it doesn't make sense to me that it would have much of an impact. I think that if we could push the bone marrow to, in the direction of making things like osteoblasts over adipose cells, I think that's that's more of like a factor thing, right? Like we're pushing the mesenchymal stem cells to do that. Agreed. So I don't know that adding stem cells would do that. So I think that really what I'm hoping for here is to say, look, let's use PRP, A2M, BMAC as a tool to help us to be more optimal, to help us to be more active, to use the joints that are maybe aching and arthritic, because we need to be able to do the things to optimize not only our bones, but our bodies overall. So 100%. I think this is a really cool way to do it. And I'm looking forward to doing the rest of my protocol as well.
Totally agree with you on that.
Yeah. Awesome. All right. Thanks, Rich.
Yeah, you're welcome. Thank you.
All right. I hope you enjoyed that interview with Dr. Schaffer. Now, clearly, this was not really looking directly at something for osteoporosis. And I know a lot of people want stem cells to do something for osteoporosis, but I just don't think that the literature is out there to support that approach right now. However, if you're struggling to be able to do the type of activity that you want to do, if you're having joint pain that's limiting you from loading your bones and lifting weights, this is something that could potentially benefit you and get you on the right path for your bones. So again, I would encourage you to take a look at QC Kinetics and see what those offers are. I have no relationship with the company other than my personal friendship with Dr. Schaffer. If you are still struggling to put together your personal bone health program and you haven't been to our masterclass yet, please come to our masterclass. We run this thing about every 1 to 2 weeks, depending on my schedule, and it is a totally free opportunity to hear how we put together a comprehensive drug-free bone health program. We talk about all the different components that could potentially go into it, and then we leave about 15 minutes for Q&A at the end. So if that interests you and you're on YouTube, look for the link in the description below. If you're on a podcast, then go to our website, optimalhumanhealth.com, and you can find a link to get onto the masterclass there. Thanks so much for listening.